let me just set this up and we're good to go.
Beautiful. Okay, this is like too big of a turnout. What they hate.
Really?
Because
It's all for you, Tisha. All for you.
The more questions are going to be.
Nah, you'll be fine.
Oh, do you mind?
Sorry? Yeah. Go for it. There's cool taps around the corner. Yeah. Okay, it's recording. So all you need to do is they get the nice slides.
Yeah, I know. Yeah. Does it work if I just click as well?
Yeah.
Because then I can just like hold and then do this at the same time.
Yeah, literally, that should work too. If anything fucks up or anything along those lines, just let me know and I'll come down. I should be sitting somewhere.
Yeah, beautiful. My note is fine. Okay, cool. All right. And let me know when I'm meant to start. Sorry. Let me know when I'm meant to start.
You can start now. It's just starting recording, so go for it.
Oh, beautiful. Okay. All right. All right, so hello everyone. My name is Tisha. I'm one of the fourth years. I'll be covering endocrinology and hematology. Two things. Firstly, I know there's a lot of slides. I went a bit overboard and there's like 200 plus on the pre-slides, but that's okay. We'll be going through just like the salient points for each slide. And I've just included the details because often hematology and endocrinology aren't covered very well. And I've just got like one slide on each of the conditions so that your entire matrix is kind of done for those two. So if you want to go back to any of the sites for additional details, it's all there. The second thing, so the font is meant to be normal. This happened when we put the slides onto this computer, so I didn't choose this extravagant font, although it's kind of growing on me now, so. All right, so I'm sure you guys have seen this breakdown multiple times throughout today. Usually endocrinology and hematology are relatively low yield, but the examiners liked to trigger us a little bit last year, and there was, sorry, that's a 6, I don't know how well it's come out, so 6 questions on hematology and 8 questions on endocrinology. So that made up a total of 14 marks. And then on exam 2, they asked us questions in basic sciences and pathology as well for hematology and endocrinology. So unfortunately, it does tend to come up. And these are the main topics I'll be covering, particularly disorders of glucose metabolism, so diabetes, thyroid disease are the main things to know for endocrinology. My guess for this year for OSCEs is that they might chuck in a thyroid station, whether that be history or examination. And for hematology, anemia, hemolytic anemia, bleeding disorders, and plasma cell dyscrasias or multiple myeloma are the big topics to know. For heme, they might chuck in anemia as an OSCE, but they'll often couple it with something else. So it might be like a colorectal cancer history, but you've got to recognize that there might be an underlying anemia there because of the chronic GI bleeding. So one of the sample questions, a 46, I'm sure you guys have access to past exams that Monash posts up on Moodle, but the last year's exam was actually very different. It was a lot more clinical and a lot more focused on your reasoning. So a lot of the times you might have noticed in past exams, you're like, well, it could be option A, B, or C, and you take it to your tutor and they're like, oh, no, but I would pick option D, E, or F. But the good thing last year was that, that even though the questions were all new and relatively difficult, they all had a very clear answer to them, and that's whether you knew the condition or not. That's how they differentiated the students. So a sample question from last year could be, and this is, I've kind of changed it around because obviously we're not allowed to repeat questions. 46-year-old female presents to her GP with muscle spasms and generalized weakness. Vital signs are performed which reveal a sinus tachycardia. Upon application of the blood pressure cuff, spasms of the hand were exacerbated but relieved once the cuff was removed. Other than having a thyroidectomy 2 months ago, she's otherwise well with no chronic conditions. Full blood examination, liver function test, and thyroid function test reveal no abnormalities. So when you get this sort of question, particularly when it's mixed in all the other neuro-renal cardiovascular questions, you kind of go like, what the heck is going on here? But then you can try and break down the question. So firstly, the main thing is muscle spasms and generalized weakness. That's fairly non-specific. But this is a bit interesting that she's getting spasms of the hand when the blood pressure cuff was applied, and these were relieved when the cuff was removed. Thyroidectomy 2 months ago seems a little bit interesting. One of the main complications we're worried about is potentially damage to the parathyroid glands. If you damage the parathyroid glands, you'll obviously end up with hypocalcaemia. And one of the signs of hypocalcaemia is Trousseau's sign, which is when you apply the blood pressure cuff, you get spasms of the hand. So you can see how it's very long-winded, and they don't even want the diagnosis, they want management. So if someone has hypoparathyroidism, something you might give them to treat that is calcitriol. So this is a difficult question, obviously, but notice how they really want you to work through pretty much all the different systems and get to a diagnosis of hyperparathyroidism. 29-year-old pregnant woman at 26 weeks gestation presents to your practice for evaluation of gestational diabetes mellitus. And you kind of go, hang on, we're not meant to be asked women's questions, that's all next year, but then you realize that gestational diabetes mellitus is something you need to know a little bit about, I guess mainly just diagnosis, and that it happens in pregnant women. The investigation you want to conduct for someone to figure out whether they have gestational diabetes or not is an OGTT. So here they're not so much testing you on your knowledge of women's health, more about do you know what the different investigations for diabetes are used for. Yeah, so they tend to use simplest as part of like their like stems last year, but it is technically meant to be the simplest because they want to try and figure out the diagnosis here. So gestational diabetes can't be evaluated using random blood glucose, fasting bloods, or HbA1c. Like if you get an elevated reading, it pretty much means nothing for gestational diabetes. You've got to do an OGTT. Yeah. And then 66-year-old male with previously elevated fasting blood glucose attends to your practice to confirm a diagnosis of type 2 diabetes mellitus. Here, once again, we're trying to pick the simplest investigation, but to confirm diagnosis. And I guess, once again, you can argue that a random blood glucose would be the simplest, but according to guidelines, to confirm a diagnosis, you want to try and use the same type of test to confirm it. So because he had a fasting blood glucose done before, you want to do another fasting blood glucose. So notice how they really are getting very clinical with these questions. And then 42-year-old man presents with bruising and hemarthrosis of the knee to the GP. The joint is tended to touch with stiffness, but otherwise the patient is able to weight bear and walk. He denies any trauma to the knee. Otherwise, the patient is systemically well, afebrile, and vital signs are within normal ranges. His past medical history only includes rheumatic heart disease, which was surgically treated when he was young, and a urinary tract infection 2 weeks ago, for which antibiotics. So now you're just like, oh, bro, can we settle here? Because there's so many things going on. So firstly, this guy's presented with bruising and pain in the knee. So there's a whole bunch of differentials for that. The joint is tender, and there's stiffness, so maybe it could be an MSK cause, but he denies any trauma. As well as that, he's systemically well, so unlikely to be like a septic arthritis. His past medical history includes rheumatic heart disease. It's a bit random, but this was surgically treated, so maybe he had a valve replacement. Maybe he was put on some sort of anticoagulation as part of that management. And then he got a UTI for which he received antibiotics. And we know anticoagulants like warfarin tend to interact a lot with antibiotics. So he's probably got bleeding and bruising from his change in INR. So the answer here is actually coagulation studies INR. These are the difficult questions. Does that make sense? Yeah. So, yeah, any questions? Right. So the reason why I wanted to put these in is to show that it's no longer just broken down into the different systems. You might need to incorporate all of your different knowledge from the different systems to try and figure out what the answer is. All right, so we'll start off with endocrinology. So this is obviously your matrix. Unfortunately, out of the 8 questions for endocrinology last year, 5 of those were the red conditions. So Monash being like, oh, I'm still learning, more like I was never gonna learn this, but anyway. So I've just got the first couple of slides going through a lot of what was part of last year's endocrinology content. So I'm gonna skip it, but I've only included it because it's good to get a refresher if you don't remember some of the different pathways. But we're gonna skip all of this stuff, and this is just stuff you can learn in your own time, but we will talk about pituitary disease. So, oh, this font is getting to me now. Okay, never mind, I don't like this anymore. But so pituitary adenoma, hopefully you guys have got the pre-slides, which has got a more legible font on there, but anyway. So pituitary adenoma is a benign tumor of the pituitary, and it can be either secretory or non-secretory. It can be of many different types depending on the type of hormone it secretes, but the prolactinoma is the most common. Your signs and symptoms are going to be dependent on the type of hormone that it secretes, as well as the size. So if it's a microadenoma, you'll pretty much just get the features of the excess hormone. Whereas if it's a macroadenoma, you might also get underproduction of the other hormones because the normal functional tissue is replaced. And you might get mass effect as well. So headache, bitemporal hemianopia, and diplopia. Diagnosis is pretty much achieved through a cranial MRI, but you might also measure their hormonal levels as well. And management, the main thing to really remember is the curative management, which is surgical resection. Specifically, hyperprolactinemia is when there's overproduction of prolactin, and the most common cause for this is the pituitary adenoma. So that's going to have various effects on the body, and that's going to manifest in depending on the type of hormone that's being affected. So obviously, increased prolactin means you're going to get galactorrhea, particularly in premenopausal females and males with gynecomastia. Low LH and FSH may cause irregular menstrual bleeding in females and infertility in both males and females, as well as reduced testosterone, which might manifest as loss of libido. Low estrogen in females may also cause vaginal atrophy, menopausal features, or osteoporosis, and diagnosis is achieved by serum prolactin. This is like a little pathway, a diagnostic pathway that I took from AMBOSS. AMBOSS was really good at covering a lot of the pituitary adenomas. So it's just trying to figure out when you might consider other differentials and what additional tests you might order. But if they give you like a person in the stem that has galactorrhea and elevated serum prolactin levels, it's most likely going to be a prolactinoma. Growth hormone excess is an umbrella term for gigantism and acromegaly. So gigantism occurs in children and acromegaly in adults. And the pituitary adenoma is the most common cause here. And because you have increased levels of growth hormone, you're also going to have increased levels of IGF-1. The way that they present is through something called macrognathia. Not very good at saying it. So that's when you get enlargement and protrusion of the jaw. And often in the stem, they might talk about snoring due to OSA or widened fingers. So their wedding rings had to be resized or they had a change in their shoe size. Might also get mass effect by temporal hemianopia, particularly with growth hormone pituitary adenomas because they tend to be quite large. And they might also have features of diabetes or hyperprolactinemia because the infundibular stalk gets damaged. And that means the inhibitory signals to release prolactin are reduced, so that you get increased prolactin, if that makes sense. Yep. So diagnosis, measure their growth hormone levels, measure their serum IGF-1, and might do a cranial MRI to actually look for the adenoma. Good one. Okay, so management got covered up by this thing, but once again, it's just surgical resection. So this is just a diagram showing the difference between gigantism and acromegaly. So with gigantism, they have growth hormone as a child that's too high. So they get growth of their bones, and that's why they end up really tall. Whereas if the epiphyseal plates are closed and then they have growth hormone excess, that doesn't tend to cause elongation of the bones. Instead, they just get the facial features. Then there's syndrome of inappropriate ADH secretion, which is just too much ADH, typically due to iatrogenic causes like SSRI, carbamazepine, or neurosurgery, but it could be due to an ectopic source as well. Because they have increased ADH, they're going to have increased aquaporin channels, and that produces concentrated urine. And they end up with euvolemic hyponatremia. The signs and symptoms are going to be fairly non-specific and similar to what you get in just regular hyponatremia. So how we're going to diagnose this is measuring their sodium levels, plasma osmolality, urine osmolality, and plasma ADH. And management, you don't need to know too much about, but it's there in case someone's interested. Hyperpituitarism is when there's underproduction of hormones from the pituitary. And the one that Monash loves to give is Sheehan syndrome, which is when you have significant bleeding and that causes pituitary infarct, typically after giving birth, so women that have postpartum hemorrhage. They might also have congenital deficiencies in things like growth hormone. That might be Coleman syndrome. And Coleman syndrome also presents classically with anosmia or no sense of smell. Pathophysiology is going to be dependent on the hormones that are deficient as well as the signs and symptoms. So once again, if you get a deficiency in things like LH and FSH, they might get hypogonadotrophic hypogonadism, infertility, loss of libido, and then prolactin, growth hormone deficiency, TSH, all that sort of stuff that you guys know from endocrinology. So obviously TSH deficiency, they might get hypothyroidism. So I'm not going to run through these in too much detail because that's kind of self-explanatory. Diagnosis, measure their hormone levels, and management, give them hormone replacement therapy. Diabetes insipidus is when they have insufficient action of ADH, which could be central, so they're not producing enough ADH, or it could be nephrogenic, which is when there's defective ADH receptors. So they present with polyuria, nocturia, polydipsia, and dehydration because they're getting rid of all their fluids. And once again, diagnosis pretty much the same as SIADH, so UECs, plasma osmolality, urine osmolality, and you can do something called a water deprivation test and desmopressin test as well. And the explanation for those are kind of in this diagram here. Once again, management, if it's central, give them desmopressin, or if it's nephrogenic, give them thiazide diuretics. Just note, by the way, that the yellow stuff is probably the main things to note, which is why like management and diagnosis, don't worry about that too much. Move on to diabetes now. So with diabetes, you do need to know this one in a fair bit of detail. And starting off, we need to know what the different tests for evaluating blood sugar levels are. So there's random blood glucose, which is a non-fasting measurement, fasting blood glucose, which is after they've fasted for 8 hours, and OGTT, which involves them coming in fasted. You measure their blood glucose level, so essentially you get a fasting blood glucose. Then you give them 75 grams of glucose, and you measure it at 1 hour and at 2 hours, and you see how well that body was able to cope with the glucose load. That's typically used for diagnosing things like impaired glucose tolerance or impaired fasting glucose, which are your pre-diabetic conditions, or gestational diabetes. And you can have glycated hemoglobin, which is looking at glucose tolerance over time, approximately 3 months. These are the different values you can get for diagnosis. The main one to really know is type 1 and type 2 diabetes. So the rule that everyone learns is 7-11. So if your fasting glucose is greater than 7, and if your postprandial or random glucose is greater than 11, that's considered too high, and you might be at risk of getting diabetes. And if it's greater than 6.5% on HbA1c, that's considered high and sufficient for diabetes. So we'll start with type 1 diabetes. This is hyperglycemia secondary to insulin deficiency, typically seen in children. It's due to genetic and environmental triggers, i.e. they don't really know what happens. And it's a type 4 hypersensitivity response to pancreatic beta cells, which means that they can't secrete enough insulin. Signs and symptoms, your classic polyuria, polydipsia, and polyphagia, but many of them might present for the first time with DKA. Diagnosis, obviously measure your blood sugar levels, but definitely consider C-peptide, anti-GAD, and anti-A2 beta. The last two are antibodies that are generally positive in patients with type 1 diabetes. And also consider ancillary tests like serum or urinary ketones to see if they are indeed in ketosis. Management is pretty much insulin, and if they're young, you might consider CSII or continuous subcutaneous insulin infusion, which are kind of pumps that secrete insulin based on their blood sugar levels. So you don't have to give them needles. They can just wear this little thing. And obviously consider lifestyle and factors and referrals as well for these patients. Diabetic ketoacidosis is a classic that they can chuck into your OSCE. So the definition is an absolute insulin deficiency characterized by hyperglycemia, ketosis, and acidosis. Typically seen in pediatric patients or the elderly that already have a diagnosis of type 1 diabetes, or they might present for the first time with DKA as well. Etiology, it's kind of just they've got some sort of stress on their body. So it could be iatrogenic, where they just haven't taken enough insulin. Could be something like infections or exacerbation of their comorbidities. Pathophysiology is fairly complicated, but I guess TLDR, because they can't utilize the glucose, they end up forming ketoacids and using those instead. That results in acidosis, and to compensate for that acidosis, the body tries to shift its electrolytes in weird ways, and because of that, they end up with hyperkalemia and electrolyte disturbances. So the way they present is sudden onset of very non-specific symptoms, but they might have a history of polyuria, polydipsia, and polyphagia. So if you do get a patient in your OSCE that seems to have low GCS, nausea, vomiting, those sorts of things, don't ever forget to put a BSL on your investigations. Diagnosis, do a urinalysis and ECG, UECs and CMP, BSLs, ABGs, and specifically serum ketones as well. And you can consider special tests for type 1 diabetes like C-peptide and the antibodies we talked about earlier. Oh, sorry, bit of a rude word, didn't warn you guys. So I remember the management using this lovely acronym. So this was taught to me by one of the 5th years. She was so lovely, so she taught this to me. So F stands for fluids, U is try and find an underlying cause, A is anticoagulation, so the C coagulation. K is monitor their potassium, I is insulin, N is keep them nil by mouth, and the G stands for glucose. And obviously after every emergency presentation, you want to chuck in at the end, oh yeah, I'd love to admit this patient and monitor them and all that sort of beautiful things. But obviously if you're in your OSCE, you want to make sure that you do it in a very I guess, in an orderly fashion. So I actually used to change it around to that. Sorry, that doesn't really work well. But you want to give them fluids, monitor the potassium, then consider insulin, keep them nil by mouth and give them glucose after. And coagulation and underlying causes are kind of the things you want to consider at the end of your management. Don't forget doctor's ABCD at the start as well for any emergency presentation. Prediabetes, don't need to know too much about this, just that you can have two types, impaired glucose tolerance and impaired fasting glucose. So impaired glucose tolerance is higher than normal sugars, and impaired fasting is when it's elevated in a fasting state, but none of these are high enough to be classified as overt diabetes. And you pretty much do an OGTT to identify these. Yeah, cool. Type 2 diabetes is insulin insensitivity that eventually results in deficits in insulin secretion as well. So EPI, it's very common, and particularly in Addison population. Etiology, tissues develop resistance to insulin due to things like genetic predisposition, physical inactivity, aging, or obesity. And pathophysiology, not really clear, but they think they have blunted responses due to this resistance. As a result of that, the beta cells and then the pancreas start to hypertrophy. And with that comes amyloid peptide deposition. This amylin is toxic to beta cells, so that actually results in cell death as they get later into the disease, and that then results in relative insulin deficiency. Signs and symptoms, they're often asymptomatic, so you might actually want to ask about risk factors and complications of diabetes. Diagnosis, the main things to note here are if they're symptomatic, you just need one elevated reading of blood sugar levels and that's sufficient. Whereas if they're asymptomatic, you need 2 elevated readings, preferably the same test. But just make sure that if you did a HbA1c last week, you don't do another HbA1c a week later because it's obviously going to be elevated. You can only repeat the HbA1c if it's after like 3 or 4 months. And you might consider an OSD risk assessment, which is kind of a screening tool for diabetes. There's key areas to address with management. The first is lifestyle and non-pharmacological, so that's particularly SNAPs. Do we know what SNAPs stands for? Okay, good. Pharmacological, metformin and others, and then referrals, keep like 4 or 5 in your mind. So patient education and structured care might include things like obviously telling them what it is, that they need to self-monitor. They might need to go off driving, particularly if they have like reduced vision and that's what they're presenting with. If they're traveling, make sure they take all the medications with them. If they're fasting for religious purposes or for surgical reasons, make sure they know how to get around that, and complications, which I'll talk about later. Pharmacology, metformin is the first choice, and then second line agents should be added to metformin, and if none of those are effective, consider insulin. That's kind of that summarized down. And then there's a whole bunch of different values you want to know for their targets. So 7% for HbA1c, 4 to 8 for fasting BSL, and less than 10 for postprandial BSL. Make sense? Good. So these are the whole bunch of medications that you can use for diabetes. I've kind of popped in the main points about these, but to be honest, like I feel like you can read through most of this in your own time. Just remember metformin. Like don't get stressed in the OSCE and go straight to sulfonylureas. Make sure you always mention metformin as your first line. And then this, kill myself, okay. Literally, I'm so done with this. Okay, so this is hopefully normal in your PDFs, but metformin is first line. And then if that doesn't work, you can consider sulfonylureas, DPP4I, so the DPP4 inhibitors, or SGLT2 inhibitors, second line. And then after that, you might consider something like insulin. So you don't need to know too much about this diagram, but this is straight from the guidelines. So metformin, then you can use any of your 3 agents as second line, and then insulin if nothing works. Insulin therapy, the main thing to really mention is basal insulin is the most common. So that's when they get one needle in the morning or at night, which is long acting. And then they take their regular diabetic medications postprandially for short-term control. But obviously, if none of that works and they need to go on insulin completely, you'll use a basal bolus regime. This is like a whole bunch of different insulins you can use. I wouldn't bother memorizing all of them. Just pick like a couple of short acting and a couple of long acting to kind of like make yourself sound really sophisticated in the OSCE. So the ones I used to remember was Lantus as my long acting and NovaRapid as my short acting. And then obviously lifestyle and prevention. So physical activity, got to get that exercise in, moderate intensity, all the HACCP stuff. Diet, low GI food, cereal, whole grains, dairy foods. Weight 5 to 10% weight loss is considered therapeutic. Smoking, cease if possible, and alcohol less than 2 drinks a day. Make sense? Beautiful. Oh, and then once again, this is straight from the guidelines. These are all the different types of people you can refer to. So I definitely reckon like memorize maybe 2 or 3 of these to suss out in your OSCE. But don't forget a diabetes educator as well. That's like a really big, important one. And then there's a whole bunch of complications. Oh, this is not come out well. This is meant to be on this side, but anyway. So microvascular might include retinopathies, neuropathies, and nephropathies, whereas macrovascular would be cardiovascular, cerebrovascular, and peripheral vascular disease. I'm sure the people that are covering cardio lectures or neuro lectures will go through this as well. And then how you might treat them. I've got a little summary in case you want to write it out in your OSCE. So last year we did have a diabetic foot exam, and they did want us to discuss very briefly like how you might manage peripheral vascular disease. And if you have a diabetic ulcer, what would you do? That's diabetes. Does that make sense? All right, the thyroid. Sorry if I'm going a little bit fast. Okay. Hyperthyroidism refers to clinical, physiological, or biochemical response to elevated thyroid hormones. There's hyperthyroidism, which is excessive production of the hormone from the thyroid gland, but thyrotoxicosis is just excessive thyroid hormone from any cause. Affects about 1% of the population. Yep, cool. All right, etiology and pathophysiology. I used to use the acronym P-AGENT for causes of hyperthyroidism. So there's pituitary disease, which is, I think, the least common, amiodarone-induced Graves, exogenous use of the hormones, nodular disease, which could be toxic, nodular goiter or a multinodular goiter, and lastly, thyroiditis. This is from the kind of GP, RAC GP college, like their little summary on each of the conditions. So I guess for exam purposes, you can just use this to learn your different conditions. I'm gonna go through them in a little bit more detail with you guys today. So signs and symptoms of hyperthyroidism, I feel like most people know this. It's things like tremor, tachycardia, increased appetite, restlessness, those sorts of things, and diarrhea. So make sure you write off some of these if you're trying to elicit a thyroid history. Okay, yep. This is just more clinical features. So they can also present with a goiter, and in that you want to figure out whether this is a diffuse goiter, and that would denote an pathology that affects the entire thyroid gland, or it could be nodular goiter, which involves part of the thyroid gland. So diagnostic process, pretty much you want to do TFTs if they present with some sort of thyroid pathology, measuring their TSH and T3, T4. Then you might consider a thyroid ultrasound to look at the size and structure, and then you can do radioactive scans to see if it's a hot nodule, cold nodule, increased uptake, or reduced uptake. So that slide was pretty much this summarized, and then we can see that here there's low uptake, so this might be a hypothyroid picture or just a normal thyroid. This is a toxic adenoma because there's one nodule here, multinodular goiter because there's multiple nodules, and this is Graves' disease because it's diffuse uptake. And if you have a thyroid nodule, if you have normal or elevated TSH, you want to do a biopsy because this is non-functioning, so it's more likely to be some sort of like malignancy. Whereas if it's low TSH, that means they have increased T3, T4. So if it's a hot nodule, you generally don't have to do anything. You can treat the hyperthyroidism because it's very unlikely to be cancerous. But if it's a cold nodule, then you want to go in and take a biopsy. Management, make sure you address symptomatic relief. So you might give them something like propranolol, antithyroid therapy like carbimazole or PTU in pregnant women, but I doubt they're going to chuck that for you guys. Surgical, just take it out, and other therapies, which I guess you don't need to worry about too much, but in case they come up. And then this is taken straight from ETG. So if they have severe hypothyroidism, start them on high doses. If it's mild, start them on lower, and then continually monitor them to see if they need something like radioactive therapy or surgical removal, or whether you can just maintain the dose. So going more specifically into Graves' disease, this is autoimmune, a hyperactive thyroid due to autoimmune causes, more common in females. Yep, they don't know etiology, cool, no one cares. Genetics, yep, infections, yep, okay, cool, did not need to include that. Pathophysiology, TSH receptor stimulating antibodies are typically found, and that's what you might look for on your investigations as well. On pathology, you'll notice pale colloids and scalloped margins. So signs and symptoms of thyroidism, and they might also have ophthalmic and dermatological involvement as well. Diagnosis, look for the antibodies. Make sense? That's Graves' disease TLDR. So, oh, gotta love path. Okay, so this is just showing the scalloped margins around the colloid. That's very typical for Graves' disease. Then you got your nodular goiters. So if it's just one adenoma, then it's just called an adenoma. But if there's multiple, then it's a toxic multinodular goiter. Most of these are actually euthymic, but I'm just discussing hyperactive nodules here. So that typically occurs due to a germline mutation that causes excessive release of the thyroid hormones. And so pathology, you'll notice an asymmetrical thyroid and enlarged colloids. Once again, signs and symptoms of hyperthyroidism, but this time they might also get flushing of the face, stridor, and dysphagia, or a palpable lump because these are literally growths on the thyroid. Diagnosis, the main one to remember is an ultrasound and a radioactive uptake scan, which might show a hot nodule. Hypothyroidism, the most common cause is iodine deficiency, but in the developed world, it's Hashimoto's. And I used to remember it through the 8 I's. This is one of my worst mnemonics I've ever made. So iodine deficiency, immune or autoimmune, iatrogenic, inflammation or itis, like thyroiditis, infiltrated disease, infants, so if they have congenital defects, and inactive neoplasia or a carcinoma. I was kind of running out of ideas until I got to the last one. So clinical presentation, fair chimps. I'm not trying to be rude, it's just like what worked. So fatigue, lethargy, anemia, intolerance to cold, all your regular things that you see in a hypothyroid picture. Do we all know the signs and symptoms of hypo? Yeah, okay, good. Oh, cool, this is just the diagnostic process you might follow, but once again, TLDR, you just do the same stuff that I had on the previous slide. So TFTs, and if you notice any nodules, ultrasounds, and a radioactive uptake scan. Management, this one's really easy. You just give them levothyroxine, which is T4. Just be careful if they're old or if they have ischemic heart disease because you want to start them on a low dose. T3 for something short term like surgery or mixed edema coma, and cease precipitating medications like amiodarone. And then obviously review all the other medications to make sure it's not interacting with their thyroid hormones, and consider anticoagulation because they're at higher risk of developing clots. Subacute thyroiditis, so these refer to different types of inflammation of the thyroid, and technically Hashimoto's and Graves' disease are also types of thyroiditises, but Monash tends to put them in a kind of separate category. So, something's happening here. This meeting will end in 10 minutes. Upgrade now to remove the 40-minute time limit, Manoj? Okay, so then we have de Quervain's thyroiditis, which is referring to a viral thyroiditis. The main way these patients, or the stem will present these patients, is having granulomas within pathology or a painful thyroid. Continue. Yeah, keep going. Okay, cool. Lymphocytic thyroiditis, which is a painless thyroid with lymphocytic infiltrate and asymptomatic. Manoj, do you want to talk about palpation thyroiditis? No. No? Okay, cool. So this is mechanical damage, so pretty much just they had trauma. And then there's Riddell's thyroiditis, which is when there's excessive fibrosis. So they present with a stone-hard, woody thyroid, and they might have mass effect. That's like TLDR of all the different thyroiditises. The reason why I put this diagram is to show that a lot of the different inflammations of the thyroid start off hyperthyroid because they're getting damage to the thyroid and that releases all the T3 and T4. But then as the thyroid gets damaged more and more and the hormones start to run out, they become hypothyroid. And depending on whether this is a reversible cause, so something like de Quervain's thyroiditis, once the thyroid heals, they'll return back to euthyroid. So it's a kind of very dynamic disorder. So we can see a granuloma here, so that immediately makes you think something like viral thyroiditis. Cool, Hashimoto's. So this is chronic lymphocytic, and it's autoimmune destruction that leads to hyperthyroidism. Can be goitrous or atrophic, so it starts off with a rubbery goiter, and then they might end up getting no goiter because the thyroid atrophies. So cool, are we, yep, we're up to this one, yep. So epi, more common in females, and it's just B cells producing thyroid peroxidase, TSH receptor, and thyroglobulin antibodies. Cool. All right, pathology, you see Hürthl cell changes, fibrosis, and prominent germinal centers. And once again, they're gonna have signs and symptoms of hypothyroidism. Diagnosis is confirmed through peroxidase antibodies like TPO-AB, and then thyroglobulin antibodies, and then the TSH receptor blocking antibodies. Yep, cool. All right, this didn't turn out very well on here. That's okay. So we can see that there's lots of lymphocytes here and some Hürthl cell changes. So that's very characteristic of Hashimoto's. Then there's thyroid cancer. Oh, literally vom. This was disgusting. Okay, so there's, sorry, there's obviously 5 different types to know, and I've highlighted the main stuff you want to know about each of the thyroid cancers. So papillary increases your risk of Hashimoto's thyroiditis, lymphatic spread, and orphan antinuclei with Samoma bodies. My sister was, I don't know if you guys have met my sister, she's working at Box Hill, some of you might have. So she might have told you, this is like her proudest thing she's come up with on how to remember papillary carcinoma. So orphan Hanny doesn't have a papa, so papillary cancer, and she doesn't have a mama, so Samoma bodies. So if that helps you remember it. So yeah. And then they have all the different Ps. The main ones are most popular, so it's the most common, and positive prognosis has the best prognosis. Then there's follicular, which is hematogenous spread, and it often has a fibrous capsule on pathology. Faraway mets can't diagnose via FNA. You have to do a biopsy for these patients. Medullary will have increased levels of calcitonin and amyloid on pathology, and they often present with massive diarrhea. Endoplastic is the worst one, most aggressive. You see giant cells and spindle cells seen in older patients. They might have a history of thyroid cancer that's just gotten worse, an astronomical goiter or a rapidly enlarging mass, and airway invasion is typically the cause of death in these patients. And then a lymphoma with the main kind of risk factor being that they had Hashimoto's thyroiditis because it increases your risk by 60 times. So this is papillary cancer. We can see that these are the orphan nuclei, so they kind of cells that are hollow. Oh my gosh, what the heck? That was sorry. So this is orphan Annie. This is what she looks like. Literally got me right there. Okay, sorry. All right, and then there's follicular cancer. So we can see that there's a blood vessel there, and we can see some cancer cells in there. And once again, we can see blood vessels with obviously follicular cancer in it. So that's just more likely to be follicular. So that's why we need a biopsy for these patients, because we want to see where the cancer is going, and often it's in the blood vessels. This is medullary, and we can see all the hyalinization in the corner here. It looks kind of pink and puffy. And then lastly, this is anaplastic, which looks what I describe as a bag of feathers and very kind of dysplastic. Yep, cool. Parathyroids. Oh, okay, let's go. So we'll start with hypercalcemia, usually asymptomatic, but it gets worse if they're dehydrated. And the main cause that Monash is going to give you is primary hyperparathyroidism. You manage them with fluids, and make sure you consider a multiple myeloma screen. Or, okay, literally not necessary. Okay, so the kind of classic signs and symptoms they get is painful bones, kidney stones, abdominal groans, psychiatric overtones, and on the throne. So on the throne is referring to constipation. This is kind of like a diagnostic pathway you might follow for hypercalcemia. The main thing to remember is that for primary hyperparathyroidism, they have high calcium and generally a high PTH as well. Hypocalcaemia, on the other hand, is obviously when there's not enough calcium, typically due to hyperparathyroidism. And they get increased nerve excitability, which is why they get carpopedal spasms, convulsions, and stridor. And the main signs to remember are Trousseau sign and Schwostek sign. So that's the blood pressure one and the face one. And then manage them with calcitriol. And once again, this is another diagnostic pathway. This time, if they have low calcium and low PTH, it's more likely to be parathyroid destruction. Hyperparathyroidism can be of many types, either primary, secondary, or tertiary. The main thing to remember is that they just have increased parathyroid hormone levels in hyperparathyroidism. So either this could be an adenoma, actually I've got the next slide. So either it could be an adenoma or a carcinoma, could be secondary to things like vitamin D deficiency, or it could be due to hyperplasia of the actual parathyroid glands. Most commonly due to an adenoma though, and through various effects of parathyroid hormones, it results in increased serum calcium levels. So their signs and symptoms are going to be similar to hypercalcemia that we already talked about. And you can follow the diagnostic pathway, but pretty much if they have high calcium, high PTH, and high urinary calcium, you've confirmed the diagnosis. Management with surgical removal. Hyperparathyroidism is obviously reduced PTH, and this results in hypocalcaemia, but also hyperphosphatemia. And that's because PTH works on the kidneys to reduce reabsorption. So if we don't have PTH, we increase reabsorption. Most common cause here is damage to the parathyroid glands when doing a thyroidectomy. So they present with hypocalcaemia and might have a history of a thyroidectomy. And this time, to confirm diagnosis, we do calcium, PTH, and a normal LFT. So we know it's not coming from a liver origin. And calcitriol would be the form of treatment. So Pravik is going to cover all the other bone disorders tomorrow in MSK. But this is a nice table that probably is also going to be useful for pathology on Monday, that shows the different types, the different serum calcium, phosphorus, and vitamin D levels, PTH and ALP, and which one is elevated in which disorder. Adrenal, how am I going for time? Okay. All right. So adrenal investigations include late night salivary cortisol. So that's measuring obviously cortisol levels, and if it's elevated, consider Cushing's syndrome. 24-hour urine cortisol is once again also measuring cortisol, but so if it's elevated, it's once again Cushing's syndrome. Dexamethasone suppression test is a classic. It's looking for hormonal feedback loops. So if you're normal, you're going to have suppression of everything. If it's primary hypercortisolism, it's coming from the adrenal glands. So it's going to be high regardless of how much dexamethasone you give them. Cushing's disease is coming from the pituitary. So if you give them low dose, it's usually not suppressed, but high dose is. And if it's ectopic, it's got its mind of its own. So no matter how much dexamethasone you give, it's going to be not suppressed. And then there's ACTH stimulation test, which is when you give them synactin and measure their cortisol levels at 30 and 60 minutes. So if it's low, then you might consider something like Addison's disease. And you can measure something called 17-hydroxyprogesterone before and after you do the test. And based on how elevated this particular protein got, you might be able to diagnose them with congenital adrenal hyperplasia, but I'll talk about that a little bit more later. So Cushing syndrome is hypercortisolism from any cause. It could be adrenal, pituitary, or paraneoplastic. Exogenous steroids, though, is the most common cause. And because they have increased cortisol levels, you're going to have increased glucocorticoid activity, which is all these kind of features here, and a potentiation of aldosterone. So they're going to have sodium and water retention and reduced potassium. Make sure you know how Cushing syndrome presents. Once again, I feel like most people will remember most of this from last year. And then to diagnose them, perform an initial biochemical test. So that could be the salivary, urinary, or dexamethasone suppression test. And then perform it again to confirm. So if it's positive 2 times, then you know you've got Cushing's, and you can do a morning ACTH to see what type of Cushing's, whether this is primary or secondary. And then consider imaging as well if you think this might be a pituitary adenoma, which is usually the most common cause. And then surgical resection of the tumor is the management. Addison's disease is pretty much the opposite. You have reduced adrenocortical hormones, and primary adrenal insufficiency is Addison's disease. They don't know really what causes it, but believed to be autoimmune, and you get deficiency in the 3 main hormones, so mineralocorticoids, DHEA, or your...
Now arriving at Burnley. Change here for Belgrade.
The main way I used to remember this presentation was
Alamein
craving and increased skin pigmentation, but just be aware that if they have secondary disease, so if it's